We haven't talked about the refractory space, and maybe we'll do that just quickly. So everyone here is familiar. We have a new therapy on the market, so a new option for our patients targeting HIF with Welireg. That data was presented at ESMO 2023, and then we've seen kind of subsequent updates, quality of life updates. Maybe just if we wanted to go around, how are you using this in your practice right now? We know that the trial were primarily patients who are in the third and fourth line setting. It's being tested in combinations, but currently approved as a single agent. So, maybe David, I don't know, since it's the approval, is there a certain patient population that you say, knowing that the ORR is, about 20% in the third and fourth line setting, and the median PFS there was 5.6 months, but that's kind of where we see maybe there's a tail of the curve. Maybe there's some subset of patients who get this, but a lot of patients rapidly, are not benefiting necessarily. So how are you using this in kind of the real world setting?
So I try to use belzutifan as early as possible. Based on a sort of an inference that it's going to work better, particularly as a single agent earlier. We've certainly seen that in the VHL patient population. So in some ways, the trial 05 picked the position where it's going to work the least well. You can fail 2 VEGFs to get on that study. So I try to give it as soon as possible after 1 VEGF. If I could get insurance to pay for it, I would do it right after IO. Unfortunately, insurance, at least in our neighborhood, is pushing back hard on that concept, in part because the cost is sort of exorbitant, which is an issue. But the earlier the better. As a single agent, we should be working as a group to try to define the population that benefits early. I think we can do a better job with that than with VEGF or PD-1 because those drugs target the microenvironment. This drug targets the tumor. So there should be a genetic profile that Pavlos or Yousef or someone can come up with that's going to predict who's going to benefit. I think that exists. And if we could get that, bring it up as a single agent, because patients, once they make the transition from VEGF to HIF inhibition, they feel better for the most part. And they can be on it, as you said, for a very long time. I have patients on the drug and the predecessor to that drug for several years, and with stable side effects. It's much different than a TKI.
What do you think? Because you were just mentioning maybe it's going to be like a biomarker, a DNA signature, but there was data presented for looking at the IMDC risk groups, and I think many of us thought, oh well, it's a tumor factor, so it's going to be the good risk patients who are going to benefit the most, but that didn't necessarily seem to follow that trend. So.
Yes, without getting into a debate about how predictive the IMDC criteria are, we need to move away from clinical criteria in all settings. We need to be more mature as a field, like our lung cancer colleagues are, and insist on, tumor-based markers. And I think we can find them. Just because we haven't already doesn't mean we can't. And to me, that means doing prospective trials with samples obtained from metastatic disease, not from the primary, because it's that which we're treating. Most of what we know is from primary tumors, which doesn't make a whole lot of sense. The lung cancer folks don't do it that way. They get pieces of tissue after subsequent treatments and define what you should get next. If they can do it, we should be able to figure it out. And I want to believe you could at least increase the response rate in a selected population at least twice. And that would make a major difference. That would allow you to potentially imagine, prospective randomized trials to bring it up sooner. That's not what we're doing as a field. What we're doing with the field is adding it to all these other things, which I can understand why you'd want to do that. And adding it to VEGF probably gives you an incremental improvement, but there's no evidence that it enhances the immune response to the tumor. And without that data, we're going into the first line, we're going to the adjuvant setting. I mean, maybe that's going to work, but I would prefer we do it more rationally.
I totally agree. I think our lung or thoracic colleagues are far ahead from us in the kidney cancer field, and I think I can imagine the only step or the only trial or drug that is personalized for our patients in kidney cancer is the belzutifan in VHL mutation. I think that data was sufficient to show that if we carefully select our patients in a personalized way, a single drug would be good enough to work. We do not have to just pile up drugs, triple combination. So I would love to see much more work done in this field in kidney cancer, and much more personalized to our patients, similar to our thoracic oncology colleagues.